everybody today. I've got a little bit of sun where I am right now, so I hope if you don't have sun now, you get a little glimpse of it at some point in time today, since we are in the spring season. So we've got a kind of a packed but really good agenda, I think, to start to discuss a number of things. So, but before we jump into that, Sarah, if you can do roll call.
Sure. I will start with Jorge Ramirez Garcia.
Good morning, everyone present. Happy Friday, happy spring, and happy Earth Day tomorrow.
Shamiko Montgomery.
Good morning, present.
Good morning. Gladys Rivera.
Buenos días, present.
Manu Chowdhury.
Hi, good morning, everyone. I'm just finishing up breakfast and I'll be on camera in the next 5 to 10 minutes. But yeah, good morning. Happy Friday.
Good morning. Courtney Wood Rivera.
Good morning, present.
Good morning. Stephanie Fitzpatrick.
Present.
Leona O'Keefe. Leona, I thought I saw you.
I'm here. Can you hear me?
Let me double check.
You're really low. You're really low, Leona.
Really quiet. I'll try plugging in.
Okay, that's better. That's better now.
Okay. I'm here. Good morning.
Good morning. And I need to note that Dr. O'Keefe has moved from All Care Health to Jackson Care Connect, and as such, can still continue in her CCO representative role. And then a couple notes for you all, or one more note for you all. Andrea Kettlehut from Pacific Source let us know last night that she's actually left Pacific Source, so will no longer be able to serve on the committee. So OHA will be searching for a new CCO representative. And with that, we have a quorum. The other thing I should note is a quick note for everybody. If you are not a committee member or a member of staff who is speaking, if you can please turn off your cameras, that really helps us with bandwidth. And I will also do not roll call, but note for the record staff, myself, Sarah Kleinschmidt from the Oregon Health Authority, also from the Oregon Health Authority. We have Stacy Schubert, Allison Proud, Andy Parker, Frank Wu, Derek Renke, Katie Howard, and Carly Castaneda. And presenting today will be myself, Stacy Schubert, and Katie Howard. And I also want to acknowledge and make sure she's present, though I saw her, the Oregon Health Policy Board liaison to this committee is Kirsten Isaacson.
Great. Thank you, Sarah. Good to see you, Kirsten. I think it's been a little while, so good to see you. So everyone got the slide deck. Again, today our agenda certainly will just briefly review our consent agenda and approve the minutes. We'll see if there's any public testimony. We have not received any written testimony, but we'll see if there's anyone that wants to take that period of time in the public testimony. And then we're going to talk about upcoming program changes to center equity in this incentive program and the important work that we're doing. Then we're going to take a break, and then OHA will present their recommendations and a timeline for the 2024 measure selection. Then we'll have some discussion and wrap up. So are there any edits or changes to be made to the minutes from our last meeting last month? Or any questions or comments about the consent agenda? Leona?
Yeah, I noticed that it says that I approved the previous meeting minutes and I did not. I abstained.
Thank you.
Thanks.
Any other further edits to be made? Okay, so can I get a motion to approve the minutes and the consent agenda?
I'd like to make a motion to approve the minutes from February with the correction from Leona.
And that's to approve the minutes from March, right, Gladys?
March, I'm so sorry.
Okay, I just want to make sure it's on record. Can I get a second?
I'll second. This is Courtney.
Thanks, Courtney. Sarah, can you take us through the vote?
Sure. I'll start with Manu. Manu, do you approve the motion on the minutes and the consent agenda? I will come back. Gladys,
Approve.
Courtney,
Approve.
Leona,
Did you hear me? Approve.
Leona.
Sorry. Approve.
All right. Shamiko,
Abstain from approving the minutes, but I approve the consent agenda.
Stephanie,
Approve?
Jorge,
Approve.
and I'll go back to Manu.
Yes, thank you. Sorry about it. I approve the minutes and I acknowledge the consent agenda.
All right, that is everyone.
Okay, thank you. Have you had any updates on anyone wanted to provide public testimony?
I have not. Allison, can you confirm that we haven't had anyone?
I haven't had anyone contact me about public testimony.
And the other thing I should note is that there was not written public comment for today's meeting.
Right.
We are a couple minutes ahead of schedule, but maybe actually while we wait, just to give, in case anyone wants to give public comment, if you would let me in the consent agenda, we could go to slide 4, because I think this will be pertinent to the conversations you're going to have later.
Yeah.
So I'll speak briefly to this, and this is your draft work plan, and you'll see that it includes some specific months when you would make decisions about the 2024 incentive measure set. We'll talk about later that this is an idea. You don't have to do it this way, but I'll note that today you will hear the staff recommendations. So then the idea would be next month you would begin selecting the draft 2024 incentive measure set. Depending upon how many changes that you want to make and what process you would like to use, we have that continuing into June. It doesn't necessarily have to. It could be something you just do in May, or it could be something that takes you a little bit longer. It will depend on what you're all thinking, how many changes you might want to make, what process you would want to use. And then you'll see in July we have, and I should also say, the process previously has been selecting people messaging me. The process previously was selecting a draft set and then allowing a month for reflection and public comment. I know there's been some conversation in this committee about maybe allowing a longer period of time for reflection and public comment. And then you would choose the challenge pool, and this is a smaller set of measures that can be worth additional bonus funds. And you'll see again that there's a period where you select a draft and then you wait for additional public comment. And again, that you don't have to do one and then the other. I mean, you could bring those two processes together. And then once all that is done, you need to select benchmarks, and that will be another process that kind of is along the similar lines in terms of you'll have a staff recommendation, and then you will make your decisions. In the past, there's been a draft and then some time to reflect. Okay, and with that, I am at 9:10. I do want to note written public testimony needs to be received 48 hours before the meeting begins, so that committee members have a chance to review. So just noting that for folks who are maybe thinking of providing public comment, if there was anything that was sent in after that point, then we will include it in the meeting next month. And that is outlined in a document on giving public comment on the committee's website. With that, I think I've stalled and we're to 9/11. Has there been any other verbal comments?
I haven't gotten any requests.
Okay. Is it okay to move forward, or should we wait another minute, Sarah?
I think it's fine. It's 9/11.
Okay, great. So if we can go,
Okay.
to slide 11, Joanna. Perfect. So I'll just set up what this first block of discussion is going to be regarding. Again, overall, we're going to be talking about some upcoming program changes. Stacy Schubert, who's OHA's Health Analytics Director, is going to be giving us a legislative update. And then we're going to have Katie Howard, who is
All right,
Sarah,
I'm
you
gonna
seem to
flag
have lost sound.
Dr. Fitzpatrick. I will message Dr. Fitzpatrick. Bear with us one moment, everyone. I'm just seeing if Dr. Fitzpatrick can actually. Okay, we've lost Dr. Fitzpatrick, and she will be, I'm sure, is calling back in. Dr. Ramirez Garcia, would you mind sharing us through this next part of moving to our
Sure, that makes sense. Thank you, everyone, for the agenda so far, and we're moving right along. In this section of the agenda, we're going to cover 3 important items that all have to do with prioritizing health equity into our quality incentive program. We will begin with a legislative update from Director Schubert and Katie Howard, and a review of the CMS core set is our second item. And our third item is how do we move forward with the benchmarking process and health equity in our measurement program. So those are the 3 items in the next hour or so. Shall we begin with the legislative update?
Yes, can I ask, Jorge, we also had some issues hearing you. Let me just see. I'm going to turn my camera off. Maybe if folks, if you're not presenting for right now, if everyone can turn their cameras on and off, and then we can turn them back on when you get to discussion, I think that might help with bandwidth.
Okay, are we ready for me? Okay.
Yeah.
Great. Joanna, could you please go to the next slide? Okay, thank you. So good morning, committee members. I'm glad to be back with you again. Feels like this is becoming a regular gig. My name is Stacy Schubert. I'm the Director of Health Analytics in the Health Policy and Analytics Division, and I use she, her pronouns. Today, I'll be giving you an update about a legislative concept that I presented to you last month. And that concept was introduced as Senate Bill 967. That bill was designed to complement the equity advancing authorities recently granted under Oregon's 2022 to 2027 OHP waiver. Unfortunately, due to an administrative error, because legislative session is messy and complex and people are human, Senate Bill 967 ended up dying in committee. But the agency requested amendments to a different bill that we had moving along called Senate Bill 966. And that carries over some of the changes that were originally outlined in Senate Bill 967. There have also been some changes to the content of the bill. So next slide, please. Oh, great. So next slide after that. Thank you. We heard that community wanted a greater say in the changes that OHA was proposing in terms of the Quality Incentive Program committee governance structure. So today I'll update you about what's contained in Senate Bill 966 regarding health equity and CCO metrics. The bill requires OHA to work with community and health systems representatives to study the CCO Quality Incentive Program and propose structural changes to ensure the program focuses on addressing health equity or health inequities. OHA must submit a report to the legislature that contains recommendations for programmatic and governance changes no later than September 15th of 2024. And then OHA would, of course, continue to monitor the metrics as is currently required in statute. Next slide, please, Joanna. Thank you. The other major change we're undertaking in the new waiver period, this should seem very familiar to y'all, is the delineation between upstream and downstream metrics. This change is also designed to increase the focus on health equity. As you know, we want to create space for upstream measures that will require sustained effort throughout the next waiver period and that go beyond the typical quality measures. Currently, the incentive measures, as you know, contains 4 upstream measures. Those are the health assessments of children in ODHS custody, the kindergarten readiness metric, which is CCO systems level social emotional health, a meaningful language access to culturally responsive healthcare services metric, and the final upstream metrics is social determinants of health, social needs screening, and referral. The program will also have downstream measures that overlap with the quality measures that all state Medicaid programs are required to report, will be required to report to the Centers for Medicare and Medicaid Services. And these are called the CMS core sets. There's an adult and child core set, and actually there's also a behavioral health core set that's comprised of parts of the adult and parts of the child core set. So these downstream measures will be broken out whenever possible by demographic risk factors such as race and ethnicity, language and disability, or Real D. And eventually down the road, most likely by SOGI as well, sexual orientation and gender identity. Because these are commonly used measures, this downstream set will result in greater measure alignment across programs than we've been able to achieve so far. Starting in 2025, the downstream measures will overlap with the quality measures that also, I've already talked about that. So Senate Bill 966 lays the groundwork for this change in the Quality Incentive Program. Next slide. And this slide is just a reminder of the timeline for the move to the CMS adult and child core sets. So in measurement year 2023, the current process would continue. So the HPQMC menu would continue to be used to select the incentive measures for measurement year 2024 menu set or measure set. And then in measurement year 2024, the CMS core set would be used. And we would supplement that with the Dental Quality Alliance measures for adult oral health as possible. As appropriate, not possible. So I think that concludes what I have to say. There is one more slide. Should be familiar. Any questions about what I've just covered?
Leona?
Yeah, thanks. I put on a headset, so can you hear me better now?
Yeah,
Yes.
that's great.
Great. I'll turn on my camera because I feel a little weird not talking to you face to face. in the past, we've discussed that clinics or clinicians are having to balance so many measures that they're trying to meet, not just for OHA, but all of the private payers as well. So with the CMS core set, a couple of questions. Will OHA then require that clinics and hospitals meet all of the things in the core set, or will it be a subset? And do you think there's a chance for alignment among other payers as well if everybody starts using that core set?
I think those are really great questions. I do think there is, well, let's start with the first one. Will all of the measures in the core sets be required? And the answer to that is they won't all be in the incentive metric program. They won't all be incentivized, of course, because you all will be selecting from among them. Many, I should say many, and I don't have the core sets pulled up in front of me, so I can't, I can't actually assess this with specificity, but many, if not most, of what's in the core sets are measured by OHA and reported by OHA. So it doesn't require the involvement of the CCO necessarily, and certainly in most cases, not the provider. These are your much more kind of, if you will, traditional point of care, HEDIS type metrics. And many of them are in fact HEDIS metrics. Sarah, I think we have on the agenda, is it today or is it at a future meeting where we actually go more in depth on the core sets?
I'm going to speak right after this about the core set and the overlap between the measure menu.
Perfect.
I'm planning on covering these topics.
So you'll get a lot more then. And at this point, your second question was about alignment with commercial plans. I think by virtue of the fact that these are, much more traditional HEDIS metrics, there will be a greater amount of alignment. One of the opportunities that we had with the Health Plan Quality Metrics Committee that was I think really great in the early years of the program was that we could tweak the metrics slightly and measure them a little bit differently because the situation in Oregon is just slightly different, but that has a cost, and the cost is that we are in fact measuring it a little bit different. And so one of the big benefits of standardizing to the CMS core sets is that we won't have that, we won't have bespoke metrics that are just, slightly to the left or to the right of the way they're measured and by, maybe commercial plans.
Manu?
Good morning. So thank you for this update. I vaguely recall that Senate Bill 967, based on the update provided at last month's meeting, went into the detail of the provider. Went into the detail of the proposed member makeup. And I was wondering, is the same language part of Senate Bill 967, or was I completely mistaken? It was never included in Senate Bill 967.
Well, you're going to have to forgive me because there were a lot of versions of all of this legislation. But the original proposal was to have a health equity quality metrics committee. And that did have, it didn't, if I'm recalling correctly, it had kind of at a high level, the proposed composition of the committee, but not like, a person from this and a person from that. Anyway, that's all gone. And that is a consequence of the community saying they wanted to have a greater say in what these changes look like. So we stepped back a little bit from the health, from going straight to a new committee. And instead, OHA will be studying options and alternatives by working with the community and by working with the health systems representatives to determine what the appropriate governance and program structure is.
Okay, so just so that I'm capturing it, I'm thinking of it now kind of more from the big picture in terms of timelines. It seems as though what you're sharing based on this recent update, that we'll no longer be planning towards a transition of the health equity metrics and scoring committee until the study is performed. So we might be pushing off any evolution of the metrics and scoring committee another 1 or 2 years, depending on how the study goes. Is that correct?
Yes, you have seen the future.
I like your humor. Okay, that's great. Thank you very much.
Oh, sorry, Stephanie.
No, I was going to ask if there was any additional questions or comments. Go ahead, Leona.
I have a few more. Manu asked one of my other ones, and that was really clarifying in your answer, Stacy. Thank you. I'm curious, it may be too early, but do you know logistically what steps OHA will be taking to gather that kind of information and do that study to be presented next year to the legislature?
I mean, at a very, very high level, we are thinking we will be hiring a consultant or a contractor to help us conduct this study. We don't, we're unfortunately, not staff rich, not resource rich. So we are going to need some help in that arena. And we really want to make sure that we are engaging all the interested parties, appropriately and in ways that make a lot of sense. And that's going to take a lot of planning and then implementation of that plan, a lot of work. So that's what we're hoping to do. But we're kind of right in the middle of legislative session, and it's fast and furious, to say the least. I don't think there's any day that we don't get some last minute thing that needs to get responded to. So yeah, that's about the extent of my thinking about it, at least. I'd certainly open it up to other staff if they have put more thought into it.
I have a follow-up question to the same. I'll just jump right in. Sorry. I have a follow-up question to the same line of thought that we're on right now. As we all know, we have a very bold 2030 goal of eliminating health inequities, and the idea of the health equity metrics and scoring committee would theoretically advance that. Now that is no longer no longer in line with the timeline that we had. What can we, as the metrics and scoring committee members, provide to support to advance the goal that we have for 2030?
I think that's a really great question, and it's a huge question that I do not feel prepared to answer, off the top of my head here today. But we can, as a team, talk about that and, come back to you next month with a more thorough response. I'm sorry, I don't mean to dodge, but I think it's just a really big question. And I appreciate it so much. Thank you, Manu.
Okay, okay, go ahead, Leona.
I know, sorry, so many questions. And this question might be better answered later when it sounds like we'll have a presentation that goes into more detail on the core set. But when you look at this big picture as we move towards the core set as kind of our menu, do do you think there's going to be a big pivot in the measurements that we're asking of CCOs? And the reason I'm asking is because when there's large changes in the measurements, it's a lot of work for everyone, and it takes time, for those things to happen. And so as we think about this year and maybe even the next year, it makes me think more about keeping things as stable as possible, rather than making a bunch of changes if some big changes are already coming down the line.
So I was going to suggest that we go ahead and pivot to Katie's presentation. That way we can then have a discussion about the CMS core set, but it looks like, Lisa, you have your hand up.
Hello, Lisa Bowie, she, her, hers, Quality Improvement Director. As I presented last month, when we talk about the quality strategy and how measurement informs that, when we come back and start to update the quality strategy after we get the guidance from CMS on the 1115 monitoring plan, which does inclusive of measures, and the Medicaid quality strategy, which has a measurement strategy. So if we go back to one of those slides, the question about will and how the adult core measure set that Katie's going to present to you on, and what measures you all will be able to help inform select from that core set, that will be a collaborative process as well from the CMS realm, as in voluntold / negotiations, as well as you all in the metric scoring committee realm, as well as the community, right? So we have a whole bunch of inputs, voluntold, CMS, you all within your privy of the committee, as well as the community, right? And we have a core set and we have upstream. So the answer is no one has that crystal ball. I don't work for CMS. I work for OHA. So we will have the structures of the quality strategy that will have the metrics within that, the measurement strategy. That's what I presented last month on. We have the core set that you're going to hear about. That's our universe that we can pull from. Do we have to report the whole core set from CMS's guidance? The answer is not necessarily. That's my crystal ball from everything of CMS has told me. Do we have to report everything and anything that's the adult core? That's not what I've been told. So, and all the CMS guidance that I have is, do you have to report anything and everything? My crystal ball says not necessarily, but we're all waiting for CMS. So that's as much as I can publicly say, and private. I don't have any more guidance. So that's what we know. When we get that information, we will be coming to CCOs, the public at large, community, and we will be having that conversation and developing that quality strategy, measurement strategy.
Thank you, Lisa. Joanna, if we can move to the next slide, and then Katie, I think you had a nice segue into your presentation about the CMS core set, so please proceed.
Yes. My name is Katie Howard. My pronouns are she, her, they, and I am the Quality Metrics Surveys and Evaluation Team Policy Advisor, as well as the lead staff for the HPQMC. Next slide. As mentioned before by Stacy, this waiver period refocuses the CCO metrics into upstream and downstream. The downstream, again, will come from the CMS child and adult core sets. Today, I'll give a broad overview of the core set and how it overlaps with current downstream measures in the CCO quality.
Katie, I'm sorry, your sound is going in and out. It sounds like you're underwater to me.
So everyone try turning cameras off, and then we can try turning them back on for your discussion. That seems to help last time.
Okay. Is that better?
Slightly, it's still a bit underwatery.
Okay. I'm gonna try plugging. How about now?
It's about the same.
Okay.
But I can hear, I mean, you're not going in and out, so I can at least hear you. So maybe just go ahead and we'll see how it goes.
Is it really faint?
It was, I can hear you. You just sound like you're underwater a little bit.
Oh. I don't like being underwater. I could also call in if it's intolerable. So just, I'll talk a little bit more, but let me know. Okay, so I'm going to talk about the core stack and the downstream measures. Next slide. I think we touched on this a little bit with Stacy's response, but moving to the core set is important for several reasons. It is maintained by CMS and has broad national.
Hey, Katie, I'm sorry. I'm going to stop you. It's really hard to understand what you're saying. Do you think you could call in on your phone?
Yeah, absolutely. Okay.
What Katie's going to share with you all is really important, and Katie's really knowledgeable, so I want to make sure that we hear everything that is said. So if you all can bear with us, thank you so much for your understanding with the technical difficulties today.
While we're waiting, I'd like to ask a question, if that's okay.
Sure,
Of
go
course.
ahead. Okay.
Yeah, just wanted to double check if I'm understanding correctly that part of the structural changes that are being reviewed are that our metrics and scoring committee would move from being an OHA committee to being a committee of the Oregon Health Policy Board. So we would remain as a body and continue doing our work as the report comes in on 2024, but structurally within the organizational structure, we would move to be a committee of the board. Did I understand that correctly, that that's being reviewed?
Yeah, so if people are interested in understanding at a deeper level what is in the Senate bill, it's actually in a gross Senate bill now, which means that the amendments that are going to be accepted into the bill have been accepted, and then it was moved on to the next stage. It's currently in the Ways and Means Committee, the Joint Ways and Means Committee. And so anyway, you can see the engrossed bill. It's actually 966A at this point. And you're right, Jorge, it does make metrics and scoring a subcommittee of the Oregon Health Policy Board. And that's really because the way it used to be set up, you all were, I'm sorry, a committee of the board, not a subcommittee. The way you're currently set up is you're a subcommittee of HPQMC, which is a committee of the board. And so this just kind of, you know, if we're getting rid of HPQMC, then you would be right under the board.
Thank you.
Thank you. Is Katie on the phone now?
Yes, she is. Let's see how it works.
Katie, can you hear us?
Can you hear me? Yes.
Yes, yes, there you are.
Oh my goodness.
Great.
Quite the
Okay.
way. Okay. Okay, we're on the right slide. All righty. Moving to the core set is important for several reasons. It is maintained by CMS and has broad national input and a rigorous selection process. The move to the CMS core set will also help ease reporting burden on providers by allowing for more natural alignment across payers. Many of the measures are nationally recognized, such as NCQA HEDIS measures, and are already used by large commercial payers and other programs. The move also allows comparability across states, since Medicaid programs will be required to report the measures to CMS. Next slide.
CMS has, sorry, next slide. Okay. CMS has signaled to states for a while that it is moving to mandatory core set reporting. Previously, CMS has monitored the core set and states did not have to report on all measures. Oregon could choose which ones to report. During the current waiver negotiations, OHA indicated that the quality incentive program would be moving to the CMS core set for downstream measures to strengthen the quality incentive program and align with CMS's vision. Senate Bill 966 that Stacy just talked about would also codify the move to the CMS core set in statute. Next slide. Last fall, CMS released the proposed rule for mandatory core set reporting for the child core set and the adult behavioral health core set. In addition to mandatory reporting, the proposed rule put forth requiring full Medicaid population reporting and involved implementing demographic stratification across all measures by the end of a 5-year period. And so with those demographic stratifications, it would be all, it wouldn't necessarily be all the measures, it would be the ones that CMS identified for stratification. CMS is still finalizing the rule and we anticipate that it will be released later this year. Next slide. Oh, sorry. Can you go back a slide? We're actually a little bit off. Thank you. So last fall, or sorry, next slide. My apologies. Each core set has 6 domains. 5 domains overlap across the child and adult core set. The domains are primary care access and preventative care, maternal and perinatal health, care of acute and chronic conditions, behavioral health care, and experience of care. The child core set has dental and oral health services, and then the adult core set has long-term services and supports. Next slide. This is a list of the current quality incentive program downstream measures. 5 of the measures are on the child core set. Those include child immunization status, immunizations for adolescents, child and adolescent welfare visits, postpartum care, and finally depression screening and follow-up plan. As you can see, postpartum care and depression screening and follow-up overlap and are also on the adult core set. The adult core set also has HbA1c pore control and initiation and engagement of alcohol and other drug abuse or dependence treatment. Currently not on the core set are cigarette smoking prevalence, alcohol and drug misuse or SBIRT, members receiving preventative dental or oral health services ages 1 to 5, and oral evaluation for adults with diabetes. Next slide. The child, so for the dental measures, as you saw on the previous slide, one of the dental measures for children currently is not on the menu. And so the child core set does have these 3 measures. To fill the gap in the adult dental measures, OHA is suggesting a technical fix to Senate Bill 966 to include adult dental measures from the American Dental Association. OHA also regularly gives CMS feedback that dental measures are needed on the adult core set and has received some indication that dental measures will be added in the future. Next slide. For tobacco, the current incentive measure, prevalence of cigarette smoking, is not on the core set. Prevalence of cigarette smoking includes ages 12 and older. There is no equivalent tobacco measure on the child core set. This is partially because the interventions for tobacco use are much different for children than adults. The current measure most likely undercounts youth tobacco use due to its self-report nature and the exclusion of vaping. For the adult core set, the tobacco cessation metric comes from the CAP survey. It is broader than the current incentive measure and includes all tobacco use not just cigarettes. For substance abuse measures, the initiation and engagement of alcohol and other drug abuse or dependence treatment, or IET, is currently incentivized and is on the adult core set. The other incentive measure for substance use is SBIRT, and it is not on the core set. SBIRT covers ages 12 and older. One substance use measure sits on both the adult and core sets. Follow-up after emergency department visit for substance use for ages 13 and older. The core set also has an additional measure, use of pharmacotherapy for opioid use disorder. And next slide. That's the end of the presentation, and I'm happy to answer any questions.
Thank you so much, Katie. If all the metrics and scoring committee members can come back on camera and please ask any questions or comments for Katie. So I just want to point out and clarify too, and Katie, please correct if I'm wrong. This is going to take effect for 2025 when we're thinking about the incentive program metrics and benchmarking for 2025. And so it sounds like we'll certainly be able to have you come back and do maybe even a more extensive presentation of this, as then we have to really start to think about how to pull from this core set. And also, I think pulling off of what Lisa was saying earlier in terms of there's still some decision making to be had within CMS in terms of the process and how much is going to be voluntold versus how much we can implement ourselves. But just wanted to clarify that we don't have to necessarily think of, I mean, I think we should keep this in the back of our mind. And I do have a comment about this when we get to the OHA recommendations thinking forward, but this is not going to be taking effect for 2024, it'll be taking effect for 2025.
Absolutely. So this is for 2025, and we know there's a lot that goes into investigating and learning about new measures. So we wanted to introduce this now, but this is something that we'll really be working with you over the next year to crosswalk and dig into the measures.
Great. Manu, go ahead.
I just wanted to share for the good of the order that next week I'll be in Chicago at American Dental Association's Dental Quality Alliance meeting. And that was noted on one of Katie's previous slides of taking the adult dental measure from the American Dental Association and its subcommittee of the DQA. And also what was noted on one of other Katie's slides that Senate Bill 966 includes that the adult dental measure would come from the DQA. Just wanted to call that out from an oral health perspective, just to kind of inform everyone on the committee here. Thank you.
Thank you.
Senate Bill 966, it doesn't currently include it, but we're asking for a technical fix.
Okay, thank you for clarifying that.
Any other?
Sorry, I did have a follow-up. So let's say hypothetically the DQA of the American Dental Association comes back and states that they're not interested in, and I don't know, I haven't been there, I'll go there next week, but they're not interested in advancing oral examinations for people with diabetes. And that's been one of our that is our adult dental measure since I think 2019. Could there be dialogue in Senate Bill 966 that it's being requested that it would be either to move with the DQA or to think about what we have? And I don't know, this is just a thought that I wanted to raise to give that leeway regarding already the steps that have been taken to advance the connections of diabetes as a chronic condition and dental disease as a chronic condition.
I just want to flag that oral evaluation for diabetes, the Dental Quality Alliance has that measure.
Okay, perfect. Please nix what I just said. Thank you, Sarah.
Other questions, comments for Katie? Okay, thank you again, Katie, and we look forward to having you come back and join our meeting as this work and as these important decisions move forward. So thank you.
Thanks
So-
for having me.
Yeah, of course. So now what we want to do, still kind of continuing this overall discussion about centering equity and making sure that that becomes kind of the foundation of our work and that we're doing everything with an equity lens. As you all know, for the first 3 months of this year, we did a lot of kind of information gathering. We had several different folks from OHA, from different departments come and present to us about where things are in terms of collecting the RealD data. Also a nice summary that the OHA team is putting together in terms of what other states are doing to set these kind of equity benchmarks. And so what we want to do now is kind of engage in a discussion in terms of where we are and where do we need to go to be better positioned to start to develop some equity-based benchmarks for specific metrics moving forward. But the first, go ahead, you can go ahead, Joanna, thank you. But the first question, and I think we've kind of skirted around this, or I might throw it out with an answer as opposed to a question, but I think the first thing we need to do and just kind of have on record for the OHA team, not that I'm going to take a vote, but I might ask everyone to at least give me a verbal answer, is can we stratify and or set benchmarks by RealD for the 2024 incentive measure set? Are we ready to do that right now? I say no. I'll start. I say no. Can I get some other verbals?
My hesitation is the RealD data that we have and how accurate or inaccurate it is. And so my thinking is if that data is not very accurate, which is my impression, then setting benchmarks is not the greatest thing at this point. But I do think that we should be thinking through how we would actually set those benchmarks as soon as possible.
Yeah, I agree with that. This is Courtney. I think that we should continue to stratify the measures for monitoring purposes by RealD elements. But I think knowing that there's a ton of work happening that we've obviously heard about over the past few months related to RealD repositories and data collection from both OHA and the CCO side, that it seems like we're positioning ourselves well to be able to do this in the future, but that we're not quite there yet. But I do agree with Leona that I think it's a good idea to visualize how we may go about doing that when we do feel comfortable with the amount of data that we have.
Okay. I want to hear from everyone.
This is Manu. I'll go next. For me as well, this is a no. I think we should continue to monitor, not ready to set benchmarks. I've shared over the last few months my concerns around the definitions for disabilities and making it more inclusive. I feel as though that the disability definition is held in the 2005 definition. And I think, again, it needs to be more inclusive for the benefit of, or the intent of what we're measuring. Thank you.
I agree with what everybody's saying. Is there a way that we could pilot a very small portion, or maybe it's not part of, maybe we don't do it, but we try. I feel like we need to take a step in some way, just to see, what would happen, knowing that is a risk. So is there like in the challenge pool, or just maybe with a region and in one small area? I don't know. I'd like to take a step forward, but knowing there's some real issues.
I too don't think that we are ready. This is Gladys and Shamiko. I really like that idea and would welcome others' thoughts, and then hearing from OHA staff on what would that look like.
Jorge, I think I haven't heard from you yet.
I do want to say that I am impressed about the investments and headway in terms of the program for a year since there is the
Jorge, you might have to call in. Your sound is really hard here. Okay, I'm assuming Jorge's calling in. While he's calling in, Shamiko, I think you also make a great point too. And so the next couple of slides, as we go through that discussion, we can talk through that and see kind of what we are positioned to do now versus do kind of over time. But so I don't want to make you think that your comments being kind of left hanging. I think it'll certainly help to look at the additional slides and then talk through that. Jorge, did you call in, or can we hear you now better?
Jorge, it looks like you right now, actually as a committee member, you should be able to, having audio problems, you should be able to post a message for everyone to see in the chat. And then if you could, I would say try calling in on your phone. It seems to be the phone audio seems to be working better today.
While we're waiting for her, because I want to make sure I give him an. Is he back on?
Sorry, he messaged me and now he's dropped off, so I bet he's calling back in.
Oh, okay.
Sorry about that. You had asked for staff thoughts. I can share those with you.
That'd be great. Thank you, Sarah.
Yeah. I hope it's really clear to everybody that there is, a lot of staff heart in moving in this direction. I'm sorry, I'll put my camera. There's a lot of staff heart in moving in this direction. And this program is so powerful and can really do really, really good things. But if we don't do this right, it can also cause harm. And I think in you'll see in the next slide, so maybe we should have done this in a different order, so my apologies. You'll see in the next slide, I think there's a ton of work that really needs to be done. And we need to come up with a plan and be accountable and do it. But I don't think even putting something in the challenge pool that we're ready. And a couple things I'll just say from a logistical standpoint. That annual dashboard that we have, it won't be until later this year that it will be updated awesomely using data from the RealD repository. So we wouldn't even have data to be testing things for you for a while. And then I think you'll see in the next slide, we're having conversations with our equity and inclusion division and even thinking through what methods might be the most appropriate method. I mean, there are pros and cons to all of them. And then Also thinking about if it's quantitative and how you do this, what is your reference group? I was on a wonderful webinar with my colleagues yesterday talking about equity and measurement. And they were, there were some really great cautions that were raised, for example, about using, white folks as your reference group, and thinking through all of those conversations. And then I think the final thing I would say is that we need community input, and it might not, doing something quantitatively might not be the thing that gets us where we want to go. So for all of those reasons, I think, and Shamiko, I hear you, like I want to go there, but I think we need to take our time and do it right, and hold ourselves accountable to the things that are on these next slides. And I'm sure there's more things that you all will add to these next slides too.
Thank you, Sarah. Do we have Jorge back now?
Not yet. I'll try and email him.
Okay, if it's okay, I am going to go to the next. I'm assuming just based off our previous conversation, just me, him, and Chair Chicken, that he's on the same page, that we're not quite ready, but these next two slides in terms of how do we get there, how do we kind of continue this work? Because that's what's got to happen. We can't just kind of keep talking about it, but how do we actually start to put some structure to this? So I first want to give a major shout out to Allison Proud, and as well as Sarah on the OHA team, just for putting these slides together in a short period of time without us really thinking about how to put this visually on paper. But I think this is a really a good start in terms of helping us to think through this. So, again, overall, moving towards establishing equity-focused measures and benchmarks, the first goal is to identify a framework for selecting equity measures. So which of, if we say the CMS core set, which of those measures do we then want to do our set equity benchmarks around? And so some steps to achieve this first goal, and some of these Sarah has already just summarized and talked about. One is continuing that work that OHA has started in terms of reviewing the processes from other states in terms of how they are doing measure selection for equity focused measures. And then also assessing the equity impact of current measures. So taking a look and seeing, based off of demographic stratification, are there certain measures where we do see disparities and gaps, and where we don't see any? If we're talking about race, ethnicity, language, and disability, certainly. And I can imagine there's a number of other socio-demographics, hopefully as the data starts to come in, SOGI being one of them, that we can think about this as well. And then continuously consulting with OHA's Equity and Inclusion Division, as Sarah was talking about, one in terms of thinking about what's the appropriate comparison group, what are the appropriate methods, and being able to do this and to select equity measures. And then community engagement, and how do we want to do that? Certainly going beyond what we do now in terms of public comment, but what are other ways in which we want to engage the community and helping us to make this decision? So I have two questions for the committee. One, what are your thoughts, feelings about this? And then what are we missing? Because there might be some additional steps that we need to consider in terms of achieving this first goal. Gladys, go ahead.
Thank you. I think the first piece is truly understanding that what may work well in the Gorge may not work well where Leona is based, or Multnomah for that matter. So I think stepping back and really looking at, there has to be some level of fluidity around what works well in what area in the state, because we don't all look and speak and we don't all have the same needs. The community engagement piece, page 3 actually, or document packet 3 within the documents that we received, talks about the social determinants of health and the social needs screening, and then it walks through a whole plan. As I read that plan, I think, why can't we replicate this sort of plan for all these other measures, right? You're working with your CCOs. You're working with those community advisory councils, because if we want community engagement, it takes it takes a while to understand this jargon. It takes a while to understand how your experience can impact a larger system. And if you're taking somebody who hasn't had that level of awareness, it's going to be really hard for them to give you valid input, or I guess not valid, but framing it in a way that they'll understand. So as I think about what's missing, it's why can't we just talk about community engagement, at least for now, that comes from the CAC groups or existing groups like that to give us that community feedback, because we're going to need our CBOs, right? We're going to need those clinics and whatnot that are going to go out and give that information to bring in that community engagement.
So just to make sure I hear you correctly, Gladys, are you saying kind of using our infrastructure in terms of community engagement that it already exists, that the CCOs have now, and start to leverage that existing infrastructure to inform this process?
Yes. It's going to take a while, right, for folks to just build on the awareness. And we already have existing groups and committees in place now that could really support these efforts moving forward. But just truly understanding that what works well in one area or the needs in one area may not be the needs in another area within the state.
Gladys, I really appreciate you calling that out. And I wanted to also clarify, because you referenced the SUH measure. It sounds like you really like the kind of qualitative community engagement aspect of the SUH measure and some of these other system level measures. And you're proposing potentially considering doing that for some of the other measures or all of the measures eventually. Is that what you were saying?
Yes, and it doesn't need to be exactly, the same process for all measures, but what I really appreciated about that 19-page document is that it really goes through all the specifics. How are we going to do it? How do we know that we're successful? How do we know that we're behind? So you're developing these very smart goals, specific, measurable, all of those goals into here's how we're going to define success, but here are all the partnerships that are included in order for us to get there.
Yeah, definitely. And I like that it provides that framework from the CCO perspective. I think the CCOs have appreciated the detailed framework to figure out how to address these different components and elements within a metric. So I definitely agree that I think that that's a good approach. My other thought is the similar subject, but thinking about our goal of trying to select measures for 2024 and thinking about, incorporating some of the community engagement aspects related to the focus on Real D or just in general feedback from the community on measure selection. And I wonder if there's a way to kind of, to Shamika's point, pilot some community engagement strategies for input from the community on measure selection for 2024. And maybe that is leveraging the CACs, because I know Sarah and I have chatted a little bit about the survey process that was implemented in 2019 for 2020 measure selection, and how surveys are potentially not always the best way to gather feedback. And it's, very subjective as far as who's actually receiving this survey. OHA doesn't have this ginormous listserv of every single community organization to send it to, right? So it has to funnel through the CCOs. So I think maybe doing something like that, but with more targeted input directly from each CCO's CAC might be a good way to kind of try and get community engagement in the 2024 measure selection process, if we feel like we have time for that. Just a thought.
Sarah's pondering, so I don't, do you have okay, because I have a follow-up to what Courtney's saying. Okay.
I'm just thinking. Okay. Go ahead.
So Courtney, are you saying in terms of sending either that same survey that we've used before or something similar to CAC members, or doing kind of like discussions or focus groups with CAC members?
I think the latter, but it would be nice to have a structured template to provide feedback back to us. So potentially some sort of combination of like a survey, but then targeted discussion with the CAC that then the CAC chair could fill out the survey to provide that information back to us, something along those lines.
Okay. And then in terms of logistics, OHA team, do you all have the names and contact information for all of the CACs to be able to do that?
So this would involve, we have liaisons and we have folks in our transformation center. I guess I'm worried about a couple things. The timeline when you have to make your decisions. And I guess as a qualitative researcher background, focus groups take training and staff, and we wouldn't have capacity to go out and conduct the focus groups. And I wouldn't want to put undue pressure on the chairs of the CACs either. And I don't know what is on the agenda for the community advisory councils either, which makes me think about the timing. I think the other thing, like longer term, is thinking about Stacy's presentation about the legislation that's being considered in the study. Some of this engagement, these are the types of groups that you would go to, right? Not just about 2024, but about the incentive measures generally. I know I'm not giving you like the greatest answer. I'm concerned about trying to pull something together quickly and not doing it well. And I'm also, I'll just be frank, I am concerned about, have the time to do it. And I'm also being told by our transformation center who is listening in that there have been concerns from some folks that there have been too many requests of the community advisory councils for those members that are in unpaid roles. So this would be another ask that we're giving them for something that they're not frankly being paid for.
Yeah, I wonder if there's any sense though of, from my experience, the CACs have been really excited to provide input on measure selection. Thinking back to that process in 2019, 2020, I think that that's something that it seems like some of them are passionate about. So I don't know if others have experience with CACs within their regions and if they have similar feelings about that. It just feels like I'm definitely sensitive to the timeline and overwhelming them with too many items. But I do feel like this is something that obviously is very important. And I do think that they all recognize the importance and would like the opportunity to provide feedback. So maybe we can think of other ways to engage them. And if that's not for this year because of the timeline approaching quickly, then maybe we, think about how to do that for next year. But do others have thoughts from?
I really like that, Courtney, and agree that maybe if it doesn't work out for this year, that we're at least building those partnerships for the next coming year, and that it really will take our CCOs, it will take all those subcommittees, it's going to take, multiple partnerships and collaboration in order for all this to work out in an equitable manner.
Yeah, and if I could just piggyback off of Gladys, what you're just saying, that, if we're in the business of promoting and advancing equity, we also have to change structures. And so if there are community members that are part of these CACs and are not being paid, they should probably be paid. They should be paid for their time. And also thinking about prioritizing the agenda so that they're not overburdened with 20 items to decide on and contribute to, but the really important items that are at the end of the day are going to impact them, their lives, and their families' lives. So I think we also have to even think about our structure and how we have things structured now and shaking that up a bit from an equity perspective. Manu, I see your hand up.
Yeah, I had a separate comment. I like the discussion from everyone else. I agree with what everyone else is saying. The only other kind of comment that I have, and this is kind of me thinking more like an engineer with wanting to know, it's one thing to review measure selection, and then it's another thing to determine if those processes by other states created the outcomes that achieved better downstream, right? more preventive care, stuff of that nature, preventing those never ever events that we don't like to see. So all I would recommend is that in the bucket of reviewing states' processes for measure selection, we also evaluate their outcome data or their epidemiological data to ensure that the steps that we're taking are really going to achieve what we desire them to achieve, which is, again, eliminating health inequities. Thank you.
Thank you, Manu. I think that's a really great point, and I think it's part of the second box. The assess equity impact of current measures in other states as well as in our own state too. So I think that's a really important point. I don't think we're going to have enough time to discuss this right now, and certainly this will be an ongoing discussion that will parallel our discussions about setting metrics and benchmarks. But I want to dig into at some point in time a little bit more what Gladys and Courtney were mentioning in terms of thinking about this two-component, a qualitative and quantitative component, in terms of how we're thinking about community engagement. There's one part of community engagement to first, how do we even go about selecting measures to set equity benchmarks for, and then there is what does that measure look like? And so I would like, as I'm trying to push us and move us forward, we got to get more detailed about exactly how we're going to do that and implement that, and what does that look like if we're going to think about this kind of two-component perspective. If we can move to the next slide, and then I can go over that goal and the steps to achieve goal number 2. So goal number 2 is to identify a methodology for choosing equity-focused benchmarks. So the first one is about just figuring out which measures that we want to set equity benchmarks for, and then how do we actually choose the equity-focused benchmarks. And some steps to achieve goal number 2, again, are reviewing other states' processes for benchmark target selection, determining the feasibility of equity benchmarks by measure, using data sources or thinking about data sources and the denominator size, simulation models using real D data and different methods. Shamiko, that's what I was thinking about in terms of something that we can hopefully do in the coming months in terms of using our existing data to simulate what would happen if we set a benchmark this way for this group versus another group. Consult with OHA's Equity and Inclusion Division. Again, we've talked about doing that continuously across the board, and certainly another aspect of community engagement when we're thinking about the benchmarks. So questions or thoughts or anything missing here?
I just really like your suggestion on simulation models. When we talk in theory, we can think that something would impact things in one way or another, but then actually seeing an example of real life, how it might impact, is always very helpful for me. So I really like that suggestion.
Go ahead, Manu.
Something that I just thought of right now, and it's probably a very a question that has an easy answer to it, but I think what we present to the CAC or the community engagement should largely not necessarily be a utilization relative to the denominator of the member size, but the denominator should be of those that utilize care, what is the percent that received a fluoride varnish or received immunization. I think that's a more actionable level of what utilization means at the provider level of care, as opposed to looking at the total population. I'm not sure if that goes here, if that goes otherwise, or I'm also not sure if it's already been included in the analysis.
So I'm not sure if it has been, but I think largely what I hear you saying, Manu, is also being thoughtful about how we present recommendations, ideas to the community in a way that's meaningful for them, so that we're not just saying, here's these bunch of numbers, or this is everyone that's covered, whether they utilized or not, but in a way that reflects something that could be more meaningful. Is that kind of what I'm hearing you say as well? Okay. All right. Courtney, I thought I saw you maybe come off. Did you want to make a comment?
Yeah, I was just going to clarify, Manu, if part of your thought process on that is around the fact that we have large percentages of individuals who don't utilize any services. So are you saying looking at individuals who are already engaged in care in general and do utilize services, and then of those who actually achieve these, metric results, basically? Is that what you're saying?
Yes, for the purpose of communication with community engagement, also for our purposes as well, to better understand what might be an achievable target versus a non-achievable target. Like, are we looking at provider behavior change, right? Or are we looking at more just from more of a population perspective? And I think it's something that needs to be discussed further. Obviously we're not going to have to right now, but I think if we're really thinking about the bigger picture, I think that's also a number that should be understood as well.
Yeah, I think that's a really good point. I think that's something that CCOs try and spend a lot of time figuring out how to better engage individuals who aren't engaged at all. And, focusing a lot of that on primary care. And I know that's really hard on primary care also. And so trying to have collaborative efforts around that. But that's kind of like the first step before you can even meet incentive measure outcomes, right? Or health outcomes, is just focusing on the pure engagement in care in general. So I think that's a good point.
I want to piggyback off these comments and just talking about framing it in a way, and I know, Manu, you brought this up at the last meeting, but really focusing on the integration of care. Just because you are seeing your primary care provider does not mean that they cannot establish or put on that fluoride varnish while they have you in the medical side, right? How do we do more of that? If you're a diabetic that you're at your dental office, you can also have your A1C checked at the chair side while you're there with your dentist, even though that's seen as a medical component, not necessarily a dental.
Yeah, one last comment to that point, Gladys. I think that it's hard because with the incentive measures specifically and the quality measures space in general, there are limitations from a data perspective. It feels like to me on where these services can occur. For example, depression screening. For the purpose of that metric, we're looking at EHR data specifically from primary care practices. But perhaps these screenings are happening in dental practices or behavioral health providers, and we're not necessarily able to capture that data into the metric. So I don't think, obviously, if we're aligning with the CMS course, that there's anything we can do to necessarily adjust for that, but it's just something to kind of keep in mind.
Joanna, if we can go to the next slide, which is more of a summary slide, just showing here that certainly, as I had mentioned before, this work is starting from, it's been started. I think it started in January when we started having our various discussions and meetings, but it will continue on over the next couple of years, certainly with ongoing consultation with the equity inclusion division, and then certainly getting a sense of the impact or assessing the impact of equity on current measures, and then reviewing other states' processes and community engagement that relates to both of our goals, goal number 1 and goal number 2, and then determining the feasibility of equity benchmarks by measure and the simulation modeling, certainly helping with goal number 2. I know we just presented this today. Certainly if folks have additional thoughts in terms of, again, what's missing or what further details need to be put into this kind of working framework, please let Sarah, OHA team know. Go ahead, Gladys.
I think the only piece that and we don't have to necessarily do a deep dive on this today, but something to note is equity costs more as far as finance, right? And the way that our systems are built right now, it doesn't pay for that work in order to take place. If you're going to expand outside of a clinic wall, it doesn't necessarily pay for that work, right? If you're going to have culturally inclusive teams, it doesn't necessarily pay for that. Motivational interviewing, so that when we are talking to individuals, they understand how to frame a question in a way that the individual comprehends that. So I think the other piece that's missing in here is the sustainability moving forward, especially for those organizations or agencies that are going to carry the work. And I just wanted to make note of that.
I think that's a really good point, Gladys. And I think about the 1115 waiver, and I know there is some movement to start to reimburse or cover things like medically tailored meals and other aspects of individual level interventions to address social needs. But I agree with you in terms of kind of incorporating some of that work and movement in terms of, does that influence any of these measures from an equity standpoint at all, and how to incorporate that. But I think that's a really good point, and that this isn't, we don't break even with this work here. So.
And we've heard it in the public testimony from some of those organizations, right? This is keeping the lights on. If we don't receive these dollars, you know, X, Y, and Z. And I think that's something for us to keep in mind.
Great. So before we had to break, I think Sarah had one further comment, and then we'll take a break.
Yeah, I was just wanted to let the committee know, of Courtney, I've been messaging with my amazing staff in the Transformation Center, and so we'll meet and talk about the Community Advisory Council and engagement, and talk about building relationships, focusing on the future. I mean, at a minimum this year, certainly we'll want to make sure that your draft set is distributed to the Community Advisory Councils, but thinking about how we can raise awareness about the program and engage with them more in the future. So wanted to note that we heard you.
Awesome. Thanks, Sarah. I think that's a really good idea too, just kind of coming up with some informational resources, even just to make sure that the CAC knows that this is the process for measure selection. And if they do have input, they can at least use the public testimony process for this year. So I think that's great. Thank you so much.
Okay, if there's no further quick question or comment, why don't we go ahead and go into a break and come back around 10:45, and then we'll start talking about 2024 recommendations. Okay. And was Jorge able to come back and join us?
It was on earlier. Let me check.
Can you hear me?
Yes.
Yes.
Testing 1, 2, 3. Working this time?
Loud and clear, yes.
Isn't technology lovely? What would we do without it?
No, it's tested the patience
It's been a fun
today, though.
Yeah, it's been a fun day. Well, hopefully this will work for the rest of between now and noon. Knock on wood.
Yes, fingers crossed. So now we're going to move into hearing from the OHA team in terms of their recommendations for the 2024 incentive measure set. And then as we go through that presentation and hear their thoughts, then we want to be thinking about how do we as a committee want to proceed in terms of how we want to make our decisions about the 2024 measure set. So Sarah's going to be presenting that, but I think before Stacy, you have some additional information to share.
Yeah. Thank you for having me back. There was a comment made right before the break, and I did want to address that, which is that these quality incentive payments keep the lights on, and it's certainly something that we've heard previously. But I just want to remind everybody that the Quality Incentive Program provides bonus funds, and they are not, and they never were intended to be spent on operations to keep the lights on. That's really the role of the capitation payments that are paid to CCOs. These are the per member per month payments that CCOs receive. whether or not a member seeks care. And those are required by federal law to be actuarially sound. The incentives are designed to fund exceptional care, and the quality incentive program, as you know, pays out every dollar every year, whether the metrics are difficult or easy to achieve. OHA also tracks the proportion of incentive dollars that CCOs pass through to their providers. Many CCOs pass through a sizable proportion of the bonus dollars, but some choose to pass along a much smaller proportion. One CCO typically pays out only about half of their earned bonus money to providers. But again, most CCOs elect to pass along a far higher proportion of what they get. So I just wanted to put that on the record because I think that's a perception that continues to be shared. And that's not the perception that OHA has. That's not the intent of this program.
Gladys, I see your hand up. Thank you, Stacy.
Thank you, Stacy, for bringing that up. And while I think we're all fully aware that these dollars are intended for these innovative efforts to meet these measures, at the same time, it still will require more money for the work to happen and to continue happening. I'll give you an example for reference. And I used this example at the last meeting as well, Healthier Oregon. It is now going to provide health insurance for individuals regardless of legal status, and pretty soon here, regardless of age restriction, right? Because it is a state program for those organizations that are now going to see more patients potentially, they're not going to get paid at the same rate as some of the other individuals. So that's just one example of an unintentional barrier that is happening because a policy has been created with good intention. And I think it's just those components that we should be aware of moving forward. Not that it's necessarily up for this group to figure out how we're going to create financial systemic change so that the work can be sustained overall.
Okay, you're good, Stacy. I just saw you come back on. Okay, all right. Thank you, Gladys. Okay, so Sarah, do you want to walk us through OHA recommendations?
Sure. So 2024 measure selection, shifting gears. I have the honor of presenting the OHA recommendations for the 2024 incentive measures set. I'll go over them. They are for you to take into consideration as you make your decisions about the 2024 incentive measure set over these next months. And they're in two parts. So first I'll talk about the set overall, and then there is another recommendation specific to the social determinants of health-related social needs measure. It's kind of like a teaser of our benchmark recommendation. So if we can go to the next slide. Thank you. So in terms of the full set of 2023 incentive measures, we recommend that all 15 measures from 2023, excuse me, be rolled over into 2024. Thinking back on this program, there has been at least one new measure included in the set in every single year since 2019. And in the last 3 years, new measures have included structural components. And so we think that the system needs some stability, and that CCOs and the partners that they work with really need time to dig into these measures. We also think that all 15 measures that you see on this slide are important to the health of people who are members of the Oregon Health Plan, and that they should be continued for another year. So we hope that you will continue all 15 measures for 2024 without addition or subtraction, so that really we can all dig in together on these. So that's our recommendation for the overall set. If we go to the next couple of slides, I'll talk about the social determinants of health measure. So in your packets, and this was referenced earlier, there is a 2-page document with our specific recommendation about this measure with some background, as well as the technical specifications. That was all in your meeting materials. But as a reminder, I'll go over some things on this slide. So this measure is meant to acknowledge and address CCO members' social needs. And it has two components. The first is a structural measure that requires CCOs to work with partners and lay the foundation for equitable and trauma-informed social needs screening, referral, and data tracking. So to summarize the requirements for that first component, it requires CCOs to look at their screening practices. So that includes things like working with CCO members on their policies. They have to assess staff training. They have to create policies on how they'll use RealD data. And they also have to assess what screening tools are used in their areas. They also have to look at their referral practices and resources, and that involves developing a plan to increase capacity of community-based organizations, entering into arrangements with community-based organizations, and they also have to establish procedures to refer members to services. And then finally, data collection and sharing. So that includes conducting an environmental scan of the data systems that are used in their area, setting up data systems to clean and to use RealD data. And then they also have to work on data sharing so that providers have access to screening and referral at the point of care. So that's the first component. The second component is quantitative, and it is where CCOs need to track and report the proportion of members who are screened for social needs, and then of those who have an identified social need, what proportion are referred for our services. So this component is the one that this committee will eventually set a quantitative benchmark for. So 2023, this year, this is the first year that the measure has been included in the program. And currently CCOs do not have to report data for component 2. The measure has a glide path where CCOs would begin reporting these data for 2024. And that would really build up the performance history so that this committee would have information to use to eventually set benchmarks on component 2. We go to the next slide. This is the recommendation. So as you saw in that 2-page measure overview in your meeting materials and on this slide, we are recommending that component 2 reporting not start until measurement year 2025. So this is technically a benchmark recommendation, but we're bringing this before you now because OHA is the measure steward, and we feel very strongly that this is the correct approach. And we want CCOs and providers and community-based organizations and partners to have plenty of advance notice that this is the recommendation that we will be making to you, and that we very much hope that you will approve. We think that moving component 2 to 2025 rather than 2024 will really give time for CCOs to focus on component 1 of the measure and really do a lot of capacity building so that there can be equitable trauma-informed screening, referral, and data collection. And there's actually a lot of action at the national level in terms of quantitative measurement of health-related social needs. So during this time, staff at OHA could track those developments and see if they impact the measure and potentially make refinements to component 2 of the measure. So we hope that you will consider these recommendations, and I'm happy to answer any questions that folks might have.
Questions? Go ahead, Gladys.
I just want to start off by thank you so much for preparing these materials. I really celebrate all of you and all of the attachments that we received. As I mentioned earlier, if we could use a similar frame for all these other measures, right? Looping in social determinants of health. How do we have CCOs have contracts with CBOs? How do we get input from community members? I think you've all done a fabulous job. Thank you so much.
Manu?
I have 2 comments. The first one actually takes us a little bit backwards to the commentary shared by Stacy and then the follow-up by Gladys. And it's something that I think I would like to open just to share, and if there's commentary after, that'd be great, because then it can help align with my thought and understanding. So so Stacy had made the comment that the rates of PMPM that are paid to healthcare providers or to the CCOs, and then from there downstream to that, are based on a capitation PMPM, which is actuarial sound. And I'm more familiar with dental. I'm not familiar with the global payment rates associated with CCOs. But for the last few years, when we say an actuarial sound dental rate, it's fundamentally based off of the costed procedure of like doing a filling or doing an extraction, based on the reimbursement that is defined and determined by the by OHA or the contractor of OHA, and so that's one piece, and I get how that works, and I agree with Stacy that that's what that is focused on, and that's what it would pay for, and particularly that would support these downstream measures that are aligned with the medical model of care. As we start looking towards upstream, like language access, like SDOH, the dollars that are paid are for the treatment of dental disease. They're not being supported towards fundamentally changing how we deliver care. And so where we are right now with SDOH, as I reviewed it, and I really appreciated that OHA was very thoughtful of a lot of concerns that I have thought about over the years with developing and integrating SDOH into provider level care. I'm very concerned about, what was stated, I think, in number 8 around overscreening, preventing member abrasion with overscreening. And I'm a little bit concerned about, okay, we have a capitated rate or payment that is based off of the costed procedures based off of utilization of care, and then the QIM dollars, or these bonus dollars, are associated with the utilization of treatment of dental disease. But as we are thinking now more upstream, where does the money kind of fall, and who is supporting the change in the system? A great example of this is that the document really highlights HIE and CIE. Many of you know that I also sit on HITALK, and I'm co-chair of the HIE work group. Right now, we don't have a state solution that connects members across the board, not members, but that allows for this member data to be shared openly and freely in order to understand if it's being done or not done. I feel like I'm kind of going off on too many different tangents, so I'm going to go ahead and pause right now, and hopefully that's room for discussion with what I've shared so far.
Stacy or Sarah, do one of you all want to respond to Manu's comments?
I guess 2 things I can say, and then Stacy jump in. We can see if maybe our actuarial services team might be able to come and give like a funding 101. It sounds like that might be helpful for folks to hear. And I think, Manu, if I'm hearing you correctly, I mean, as some of these measures do move upstream, this program is for CCOs, right? The dollars flow to CCOs from this bonus program. And the CCOs choose how to push those dollars out. But as the work moves more upstream, right? Obviously, there's always going to be work in clinics, and that's why we've talked about downstream measures and the importance there. But there's also this upstream work, and that's not just in clinics, right? Like, that's CCO staff who work on that. That's community-based organizations who work on that. And so thinking through what we mean by providers, and I know in the current CCO contracts, providers are not just clinical providers, there are partners in community-based organizations, et cetera. But I think the work we think about equity and the need to get upstream the work that needs to be done in that. Certainly, there are clinical components, but we're not going to get there by what happens in a clinic. And so the work that CCOs are doing, thinking about this SDOH measure and working with community-based organizations, they're going to need to think through how that funding works and how they shift these bonus dollars.
I think, as a definite offshoot to what you shared, the document talks about collecting the data, maybe even through an EHR-based system. And so, or through ICD-10 diagnostic codes. And so when you look at where the SDOH tool is being deployed, at this time right now, it is not integrated into the Epic platform, which is in 90 to 95% used in 90 to 95% of the health systems throughout the state. And don't even get me started about dental. There's no dentist that has Epic, or no, Medicaid dental provider that uses Epic unless they're affiliated with a community health center. And so this is just, again, I'm glad that the idea and the thought is to delay the startup component too. And always my intention is to ensure that whatever we create is something that is operational and functional, it will achieve a better lifetime of health for all Oregonians. So that's the intent I'm coming with. I'm just trying to understand how we do a more robust job of connecting the dots for everyone.
Yeah, Manu, I appreciate that. I wanted to add my 2 cents from a CCO perspective. I think, one of the things that is really cool about this measure is that it is very innovative in the sense that it does include a lot of different data sources in the component 2 portion of tracking, so that can account for, different tools that different providers may use or different community-based organizations use. But of course, with that comes challenges of reporting the data and gathering all these different data sources to then report it back to the state. So I think that's something that CCOs are trying to wrap their heads around, how we can potentially, gather all this data into one place from multiple data sources, because it is unique and different from many other CCO measures from that standpoint. So I think, there's a lot of pros and cons, but I do feel like I personally am really grateful that it's innovative and includes a lot of different data sources to account for the different systems that are in use.
If I can slightly switch gears, unless anyone has another specific comment about the SDOH measure recommendation. No, okay. So thinking about OHA's, your recommendation, and certainly I want to echo what Gladys said. Thank you all so much for the effort and the work that you all put into this. Going back to our earlier conversation about the CMS core set, and that we will be moving towards that for 2025, and there will be that's how we will select the measures going from there. And given that, from what I could tell, there's about 4 measures right now as part of the 2023 and the proposed 2024 measure set that are not part of the CMS core set. And given that we are, what I'm hearing, and I agree with this goal of stability, giving CCOs a break, that we're not adding 1, 2, 3, taking away 1, 2, 3. We're not switching up the set every single year. But we will likely be switching up the set for 2025. And so just wondering the implications of keeping the 2023 measure set with measures that will likely, that we know are not part of the CMS core set, so that I'm assuming we won't be able to pick them, but please clarify, we won't be able to pick them because they're not part of the core set. And so do we want to go ahead and think about stability maybe for 2024 to 2025, as opposed to stability from 2023 to 2024. I'm just throwing that out, but I think it's something, because there's going to be a change, if I'm understanding correctly, either now or later, that's going to break up this goal of stability.
So Dr. Fitzpatrick, just to clarify, you're suggesting that we either followed OHA recommendation of keeping the set the same, or we start integrating this towards a CMS course set for 2024. Is that accurate?
I'm not really making a suggestion. I think I'm just pointing out that I hear the recommendation and the goal to be stable, but that's only going to be from 2023 to 2024. There's going to be another change come 2024 to 2025. So do we want to potentially set up and remove those 4 that we know cannot be part of the 2025 measure set to start moving towards stability now, or not? I don't have a vote yet in either way. I'm just trying to understand the implications because of what's coming down the pipe for 2025. Leona?
Yeah, could someone on the OHA team clarify what Stephanie was saying? If we have current measures that are not on the core set, will those be able to remain in the measure set once we have to use the core set, or will all of those non-core set measures have to drop off?
So the 4 upstream measures, which are not on the core set, would stay because they're upstream. The measures that Katie pointed out that are downstream measures that are not on the core set would not be included in the program. That said, there are, as Katie was pointing out, there are measures on the core set that get at some of those concepts. So for example, around cigarette smoking, there is the CAP-based measure on the core set. So our thought in, if I may, in making these recommendations was that as part of your core set conversations that you will have over this next year, you'll really dig into those areas and think about, you know, is this an important topic area that we want to continue? And then if so, what do we think of the measures in the core set that relate to that topic? In some areas, you like looking at substance use disorder, there's more than one measure in the core set that you all could consider. And so our thinking is that you would be taking a deep dive into those things next year and looking at shifting those. And also allowing time for input from folks about which might be the most appropriate.
Go ahead, Leona.
Thanks. Yeah, thanks for clarifying that. I think it's a really excellent question. You phrased it better than I was able to at the beginning, Stephanie, of do we make the change now or later, essentially. And just thinking about the fragility and strength of our provider network right now, I'm hearing that in the metro area, there are some really strong signs of recovery after the pandemic. I'll say in Southern Oregon, we're seeing some really weak signs of recovery. So we're not in the same place. And I don't know about other rural areas if they also are farther behind in recovery. So that's concerning, but also brings me hope that if the metro area is seeing strong signs of recovery, then maybe the more rural areas will start seeing those as well over the next year, which would maybe make me lean towards waiting to make changes. But yeah, I would be really curious to hear what other people are seeing and thinking. I guess also, if we don't know everything that CMS is going to be asking at this point, then are we making changes ahead of knowing what we actually are going to need to do? Yeah.
Yeah, that's what I think. I feel like it's a little too premature to make any large decisions based on alignment with the CMS core set. And I think also thinking about, to Sarah's point, you know, if we do end up wanting to try and like swap measures that we have in place for one that, you know, addresses a similar health outcome that's on the core set, it may make sense to do that within the same year as opposed to, you know, dropping, for example, cigarette smoking prevalence and the SBIRT measure, and then determining, you know, next year what we want to add in its place potentially. I think we need some more time for evaluation. And I do agree that having a constant, steady measure set for at least 1 year, even if we know it's going to change in 2025, we can appropriately communicate that out to CCOs and providers and communities that there are changes coming for 2025, but that, will remain constant for this year. I do think the addition of one measure every single year has been really hard, especially through recovery of the pandemic, to Leona's point. So I think keeping it constant would be a good idea for this year, from my perspective.
Thanks, Courtney. How are others feeling about the OHA recommendations as a whole?
I just want to be sure to say out loud that I appreciate that OHA is recognizing what a difference it makes to have some stability, and that it takes time to invest in capacity of systems in terms of your recommendation to move component to a year out. So I think that's really insightful and helpful for the system to keep up and also to have the impact that's desired in these measures. So thank you.
Other thoughts, comments on the recommendations?
Can you hear me?
Yes.
I will also echo the importance of taking into account our healthcare system, what it has been going through, and the reality of 2023 in terms of a new leadership, new governor, 1115 waiver implementation processes, which, by the way, we know highlight health-related social needs. It seems like a fair assessment that keeping the program with integrity can serve those multiple, take into account the stability of the healthcare system, and that it can set us up for benchmarking in terms of taking into account that there has been continuity and being able to examine where the growth areas are given that continuity.
Thanks, Jorge. So can we possibly move to slide 38? Is that okay, Sarah? As we start to have a discussion about how we want to move forward in terms of making our decision about the measure set. And sorry, Sarah, if it's like you've certainly talked to some of us individually about kind of that process before, and that there was kind of a survey sent out to committee members to decide of the various measures, which one were transformational and which ones I think it was like an importance domain or something like that, or but I think right now we're at a point where we need to decide how we want to do this process for 2024 in terms of selecting our measures and how much time we want to allow or try to provide in terms of community engagement and public comment. And Sarah, please step in if I totally messed up that instructions of our next step.
No, not at all, not at all. What was I going to note? Oh, yes, that is what you need to do now, please. As staff, that will be super helpful. And I guess I could give some information on other ways that measure selection has taken place in the past. So as Dr. Fitzpatrick mentioned, there's been a couple of years ago, we had a survey. So you all have in your consent agenda the definition of transformation that the committee uses that's based off the health equity definition. And so there was a survey and committee members looked at each measure and they said, according to them, does it meet that definition? And then do they want it in the measure set? And then the committee looked at whether those things aligned or not. And that was useful in selecting the measures. In previous years where things have been in person, the committee, they literally used stickies and they kind of did went around and voted and then used that as a conversation piece. There was another year where there was a very intensive process where the committee, and it took multiple months, where the committee went through and staff presented details on each measure, and then the committee assessed the measure against their measure selection criteria. And they did it live. So we had I always want to say Zoom, it's not Zoom. We had a Survey Monkey, and so they would assess against each component of the measure selection criteria and then see it and then have a conversation. That is not something you would be able to do now because it's a month-long process. It might be something you could consider as you're looking at the core set. The other thing I would say is, I just would be remiss if I didn't say the measure selection criteria, in my opinion, needs to be revisited. It doesn't mention equity. And also actually the Health Equity Committee chairs, Jorge, I think this was before you were on the Health Equity Committee, but the Health Equity Committee chairs had voiced some concerns about, there's one of the requirements about evidence-based and scientifically relevant that's built into that measure selection criteria and not being biased. So I've given you this idea of that, but also I want to flag that for you all as that's something that you'll be looking through as you make these decisions. So just know that. So anyway, those are some of the things that you could consider. But yeah, it's really open to you all to think about how you want to make these decisions.
So what are people's thoughts on? Leona, go ahead.
Oh, yeah. Sarah, I was just hoping you could expand on evidence-based being biased so that I fully understand where the equity committee was coming from. I think I have an idea, but I want to make sure I'm not making assumptions.
I think some of it comes from thinking about what gets funded, right? And if you're looking at certain studies of certain practices, right, that certain things are going to get funded and things from other communities do not get funded. And so you're not going to have that evidence to say that it works. It doesn't mean it doesn't work, but because of systemic bias and what gets funding, you're not going to have that. So I think that's part of it. And I am not the certainly expert on this, but that is some of the conversation.
Yeah, it's what's get funded and published or put into a public domain. So it's definitely bias there.
Yeah, because one of the things that we discussed a while back, the survey is helpful because it helps figure out where everyone is and where most people are feeling strongly or not strongly. But it felt very subjective. And I think there needs to be subjective thought that goes into this. It can't all be based on data, but things like number to treat, number needed to treat, number needed to harm, cost to implement, potential dollars saved in the long run if implemented. Those are some of the objective things that I think of that cannot be done for all of these measures and take a lot of person power to do. And I understand everyone is short-staffed, but for the measures where those things can be done, I think sometimes it helps. So if measure A, you need to treat 10,000 people to improve one life, but measure B, you need to treat 10 people to improve one life. For me, that helps me balance things out a little bit from that perspective. But then I don't know how, fitting that in with the potential bias and things, because just because something doesn't have a number to treat doesn't mean that therefore we shouldn't be looking at it. So interested in other thoughts. And just acknowledging again that I think it's helpful to have both objective information, but also subjective, and be combining both of those things as we look at measures.
Thanks, Leona. I'll just take a jump and say it, and that I think, again, stating again, if the goal is stability, and we certainly have that recommendation from OHA, I'm not sure we need a full out decision-making process in terms of surveys or et cetera. I think if anything, we need to make sure and that we publicize, promote as much as possible in the community for people to respond to the measure set that is there and providing sufficient time for that to happen. Maybe a month is enough. I'm not really sure. You all who work with CACs and things like that would know better in terms of is a month or maybe 2 months is needed. But I just want to just take a jump and just put out there that I think, and it's fine too for us, I think, to kind of sit on this, just going back to early in the beginning, slide 4, in terms of that work plan that was put out. You know, we certainly could further think about, do we want a more detailed kind of decision-making process? We could do that and sit on that until May and then implement that. That's not a problem. But I'm just, based on the recommendations and what I'm hearing from those who especially work in CCO, stability is really, really helpful. I'm not sure us doing a survey or any other process within the committee itself is going to change that goal. But certainly want to make sure we elevate community voice. Sarah, go ahead.
Yeah, I just want to note a couple things about, we have in the past done an external survey. So we've done community surveys, but there's also been external surveys that provide valuable feedback. And I do want to say that the responses that we get are from people who are in the health sector largely, who have important voices, but they're not the only voices. And if there's over-reliance on something like that, the other thing I will note is thinking about a survey method as a way to try to get community engagement. And I was honestly, again, a really great webinar yesterday, and they were talking about the BRFIS and in Oregon and low response rates among the Asian and Pacific Islander community. And then there was this whole other process where they worked with community members, and community members went out and they got tons and tons of feedback using a qualitative method. And that was based on relationships. And we need to do that work. And that's what some of those slides that we went over before, but we're not there yet. So that, I guess that would be my caution about it, doing an external survey.
Yeah, I agree with that, Sarah. I remember that survey very well from a CCO perspective, and I think it was helpful, but I totally agree that it's definitely the responses most likely were from individuals who are, you know, working on this, and it is fairly biased from that standpoint. So I think I definitely hear what you're saying about incorporating, like choosing the right path forward for community engagement for future years. So, but I think trying to figure out how, with such short time, we can get community voice and engagement right now. So I think, you know, what you suggested earlier is just kind of taking it back to the transformation team and trying to figure out a way that we can maybe just make sure that there's increased communication to the CACs about, you know, the process, and that including the public testimony piece, I think would be really important. And then I think as far as the committee, Stephanie, I hear what you're saying. If we're all on the same page of keeping the measures, then maybe we don't need to have an internal committee member survey process, unless we feel like that may be a helpful exercise to do, just to do the evaluation of transformation, to make sure that we still feel like all of these measures are transformational. You know, I think that I know in years past, during like the big change from 2019 measure set to 2020 measure set, the committee went through a lot of details around you know, sustained improvement over time, but it feels like we may not totally have that because of all of the disruptions of the pandemic. So I don't even know if looking at, you know, some of that data would be helpful, but we certainly could at least evaluate the data points that we have access to, just to make sure that, you know, if there are any that stand out as continuing to sustain improvement, that we maybe consider that for even maybe not this year, but the future years when we're thinking of, you know, adopting the core measure set.
Thanks, Courtney. Others? Jorge, go ahead.
Yeah, along the same lines, I think that a strategic, focused self-study, self-assessment this year with the general intent or rising consensus, if it's fair to say, that we might have the same set. That exercise, I think, would be very valuable in terms of setting the criteria and preparing us for the next cycle, and being ready in terms of understanding more clearly how we are thinking moving forward, and selecting measures. What are the key criteria? So I would encourage us to think along those lines, that those are not mutually exclusive, going through some strategic internal exercise. Obviously, the community engagement, it's more risky to do that in some limited fashion and then turn around and say, we don't have time or there's not a lot of room. But we can certainly start designing that process for the next iteration, when we would be able to incorporate community voice. Thanks.
Jorge, can you talk more about what that would look like?
Well, I think that reviewing what criteria are used to choose measures. We talked about recently transformation. We talked about exceptional care, lights on, calibrating, where do we stand? I mean, value-based change, value-based healthcare is a really important concept. But this is a pay-for-performance model of retrospectively paying for change that for healthcare that took place. So how do we gauge the measures that we would keep in terms of those criteria? And do we have some consensus as to how we're going to move that forward to the next cycle? Another issue that I heard, which is, I think, very important, is we have a AAA model. And so understanding what are the tensions in the cost versus the, producing the change. Those are the types of things that can be very valuable to see any measure from my perspective, and see, do we want to set that comprehensively, a portfolio of measures that comprehensively provides that type of opportunity to produce change in many lives effectively, and in some cases, smaller set of lives, but with a lot of population health value. I mean, to me, those are the types of questions that are important for us to clarify. The last one that I'm not sure if we mentioned it, but I think we have certainly implicitly is domains of measures, right? We have important health topics and domains. How does our current measure set look like in terms of how many are internal healthcare delivery measures, how many, to age, health equity sensitive measures that have been recommended by measurement experts that are known to have a lot of health equity value. I mean, to me, those are a lot of important questions that we could evaluate in our current measure set and see how we're going to place value on those moving forward.
Gladys, I see your hand up. I just want to, Corey, when you say moving forward, do you mean for 2024 or 2025 and beyond?
Correct, for the next cycle. If we are moving toward keeping the same set for 2024 while we make decisions. We know that we're going to receive feedback from CMS this year, correct? And then so in 2024, we're going to be making decisions up to in 2025. And having a foundation, an important foundation this year with a, would give us, I think, a big headway for Q1 of 2024, and be really well prepared to incorporate the new changes and have those criteria a little bit, not necessarily set in stone, but be more firm and farther along the road, to make more changes to the set of measures if need be.
Thank you, Jorge. Gladys, go ahead.
Thank you. Echoing the same sentiment as others of keeping open to keeping the set the same until we hear more from CMS, which would allow us to be better prepared to make systemic change later on. Jorge, you mentioned something very beautifully about placing value. And I recognize that if we share this with the public right now, we may not get feedback from community members themselves. So how much value do we want to place on that in the future? And that means incentivizing. With some community health needs assessments, when an organization is conducting that, they will also tie into an incentive to that individual. If you're going to spend 10, 15, 20 minutes answering the survey, we're going to make sure that you're going to get paid for the time that you're doing this work. So I think having that discussion of how intentional do we want to be moving forward around how much public engagement do we actually want to receive, whether that's from CAC members, CPOP organizations, or, community members that maybe have no awareness of OHA scoring and metrics and the QIMS and, all of that overall. So appreciate this conversation. Thank you.
Thanks, Gladys. If I can try to summarize what I think I'm hearing, and it goes back to our earlier discussion with those two goals in terms of how we, equity measure selection and equity focus benchmarks and the different steps, and coming up with a framework and a plan moving forward to do that as we move forward, starting with 2025, certainly, hopefully with 2025 and on from there. And I heard a little bit about maybe we do that same survey that we've done in the past, just to see, do we still see the current measures that are there now as aligned with transformation as we saw them before? Basically, will we come up with the same measure set that we have now? So I just want to get a better sense of the plan for 2024. So I completely agree that we need a framework and we need to implement a work plan in the coming months for how we move forward with 2025 measure selection and benchmarking. What's the plan we want to implement now, knowing that we don't have as much time or resources to do what needs to be done and how we would like to do it? What can we do right now to come up with our measure set? Or what do we need to do right now to come up with our measure set? Maybe let me put it that way.
I think we've heard partners, right? Like Leona has mentioned it several times. In certain areas, workforce development might not be the same in other areas. So it is really challenging to say, okay, this is what we're going to do this year when we don't fully understand barriers that are outside of our visibility.
So is there something we can do now to get a better sense of that so that we then can develop a measure set?
I think I may be a little confused, but I thought I heard consensus to keep the measure sets the same for this coming year. That way folks already, they know what to expect because it was similar to this last year. Did I hear that incorrectly?
So that's what I wanted to confirm, because I guess I got lost in the conversation because we were talking about 2024 and then it became this framework moving forward. And I was like, are we moving forward now? Are we moving
No,
forward?
I hear you. I hear you. I
I
think
just
they're
want to
like,
confirm myself. Thanks. Can we go back to slide 37? And Sarah, if you can kind of go over what materials will be provided to us.
Sure. So before your next meeting, we are putting together a measure selection packet for you. And it will include the things that you see on this slide. So it will include the Health Plan Quality Metrics Committee measures menu. So that's the menu of measures. That's your universe of measures from which you could choose measures for 2024. It will include the measure selection criteria that was set by the committee. I think it was created in 2014 or 2015 and has those cautions that I would give you about it. It has a measure retirement checklist. So the committee has in the past created this checklist where if they're considering retiring a measure, it's things to go through and have conversations about. We will give you a history of the measure set so you can see how long different measures have been included in the program. We will have performance history, so you'll be able to see performance. We'll have the health equity definition. We will have your working definition of transformation that is in your consent agenda each month. There's a table with kind of the rationale behind each measure. And then we also have for each of the measures plain language summaries of what the measure is and what it is meant to do. And then we have the technical specifications, which are kind of the opposite of the plain language summaries. So it's a long packet. It's a lot of information, but it's meant to be a reference document for you all to use as you're making your decisions. So hopefully this helps you in kind of at a minimum what you'll be receiving.
I'd like to see these documents, and then maybe just instead of going measure by measure and having really long conversations about them, if we're heading towards the path of just choosing these measures for stability, but I just want to double check each measure just to make sure, because maybe there is something that needs to be retired. So looking at the performance history and then just doing that in our own time, taking the survey, and we could show up and say, yep, we want to keep them all. And then we don't need to think through that anymore. But I do think we need to be a little bit thoughtful about this before we just say, yeah, let's keep them all. But if at all possible, I would like to reserve our time to thinking through the framework for the future if we can.
I like that suggestion. Here we go.
I agree.
I agree too.
thank you, Shamiko. I agree.
So do I. Great suggestion.
So we'll prepare this as staff, and we're working to get it to you with more than a week before the next meeting, because it is a lot of information. Did I hear, would you also like to have a survey for committee members?
That's what I said, but of course, everybody else chip in.
Yeah, I think it might be helpful. It's just a nice way to gather our thoughts before the meeting and have a good starting point. Because there might be some that we all have consensus on already that we don't need to have a lot of conversation about. So I personally feel like it's a good idea.
Go ahead, Jorge.
I wonder if the committee would, if it would be beneficial for item number 6 to have health equity measurement selection best practices. I think the definition is incredibly important. It's state homegrown, but even just to have it on a routine basis, what are the mechanisms, what are the ways to select measures with a health equity lens or approach or intentionality?
That's part of the work
what
though,
are,
that we need to do though, right? I mean, we certainly can borrow from what other states are doing, but I think that's part of the ongoing work for us to figure out how to select measures from an equity lens and what are all the pieces of that. Because I don't think anyone's got that figured out yet completely.
well, I was thinking about measure selection and just having a way there to say there are 2 ways or 3 ways to select measures based on health equity. And one of them being is in a health equity measure. Number 2, is it a measure that is sensitive to inequities and existing disparities? And number 3, community voice, for example. And just have that as a routine in our package. And if we haven't landed on a process on how to do that, just the fact that we can start integrating that into our routine measure selection would be valuable from my standpoint, but perhaps not to the committee.
Thank you for bringing that up, Jorge. If we don't have that clearly defined ourselves, then we end up assuming, which is back to the implicit bias piece, right? Bias piece. If we're assuming what we think is going on without having that input from community members and they're telling us that this is what's wrong, it's kind of going around.
So if I can summarize, we're definitely going to get this huge packet of information to review over the next month. It sounds like the OHA team is also going to send out that survey that we've done before, just to kind of check and see where we are in terms of, at least in terms of the transformation side of things. Are we still kind of thinking about each measure the same in that sense from what we've done before? And then I hear you, Jorge, in terms of having some criteria. So there's a health equity definition, which I don't, if we can pull that up really fast, Joanna, because I think it's in this, I think it's part of the consent agenda, right? But those kind of indicators that a measure will advance health equity, which is part of the transformation definition as well. I believe the transformation is part of that is about advancing health equity. We might loosely have some indicators of that. I think there's still some work to be done in terms of deciding what that set of metrics or indicators are. And there's certainly, I think, if I heard Gladys right, there's certainly a lot of work to be done. If community voice or community input is one of those indicators and metrics, there's tons of work that needs to be done in that space to be able to even fulfill that indicator, which it sounds like we don't quite have the infrastructure to do. So I'm in agreement with you that I think it needs to happen. And maybe there's only a few metrics or indicators of health equity that we can consider now. I just think that needs to be spelled out clearly what those are, and that it aligns with the definition for health equity that we are working from, as well as the definition of transformation that we're working from. And we don't, luckily, have to vote or make any final decisions today. So, so I think where we are is that we're going to get a lot of information. We've had a really great discussion today that I think we can kind of go back and reflect on all the information is going to get sent out, use that as we're processing and doing the survey. And then when we come back next month and meet, then we can probably have an even more richer discussion about each measure and where we want to proceed in terms of taking the OHA recommendation or making some changes after we've been able to take some time to reflect a little bit more. That sound okay?
Sounds good to me. Thanks, Stephanie.
Okay. Sarah, other OHA teams, is there anything else that we should try to cover or?
The thing I will raise, and it's fine if you're not ready for it, is if anyone, if you agree with our recommendation about the social determinants of health measure, if anyone would want to make a preemptive recommendation that if you include that measure in the 2024 measure set, that you are saying that now that component 2 would not be required until 2025. And I know that's kind of an odd motion, but I think that CCOs and providers and community-based organizations might appreciate knowing that sooner, if anyone is ready to make a motion around that.
Go ahead, Courtney.
Yeah, I think that's a great idea, Sarah. I was actually going to ask if we were allowed to do that. So I think that I would like to make a motion to align with OHA's recommendation that if we do move forward with selecting the social determinants of health screening metric, that for component 2, we will not require the data reporting for component 2 until 2025.
Second.
I will do a roll call. So I'll start with Shami, or wait, do you need to have discussion? I think you need to have this.
Oh, yeah, sorry. Any discussion or edits to that motion? I don't see anyone. Okay, let's go ahead, Sarah.
I'll start with Shamiko.
Aye.
Leona,
I agree.
Courtney,
Approve.
Gladys,
Approve.
Manu,
Approve.
Stephanie,
Approve.
Jorge,
Can I vote and make a recommendation as well?
does it alter the motion?
Hopefully not. My recommendation, this makes a lot of sense to me. I'm very supportive. But my recommendation would be if we could monitor the progress on having that reevaluation of that needs to take place in terms of aligning that measure with national developments and with what needs to take place. Basically, I'm trying to assess if we can continue to be kept abreast of how that process is going and its implications moving forward. But I approve this motion.
So that's unanimous. And to your recommendation, Jorge, yeah, we can come back and Katie can give updates, periodic updates, and talk more about it too.
Great, thank you, everyone. Sarah, is there anything else you want to get out there and try to get a vote on, a motion on, or any other comments? Oh, go ahead, Leona, sorry.
Yeah, I just wanted to ask, I think we have 2 vacancies on our committee then. One CCO and maybe the other is member at large. And I know there's been some instability with the director for OHA, but can those positions be filled with the current interim director in place, or do you have to wait for a permanent director? And I'm asking because it feels like the later somebody comes into this process in the year, the harder it is to catch up if they haven't already been kind of ingrained in the process. So just wanting to make sure whoever is chosen is as successful as possible.
Totally makes sense. I'm not going to give the straight answer because we just learned about Andrea leaving Pacific Source yesterday, so I need time to look back at our processes. I'm sorry, but thank you. I totally see where the question is coming from.
I guess I'd also want to jump in and say the process of recruitment is very, very thorough, and it's done a little bit differently than when each committee under the board was kind of its own separate entity. It's lengthier than it has been in earlier years when you know, metrics and scoring operated a little bit more independently. I should say, you guys always operate independently, but the selection process is now being shared across committees of the board. And so I hear what you're saying, Leona, about wanting to try to get somebody on sooner rather than later. And I don't think even under the very best of circumstances, it's going to happen quickly.
Sarah, go ahead if you have any additional comments.
Not on that, actually. I was just going to go back and Jorge, I'll have to think of what we might be able to put in the packet around health equity measure selection best practices, because I Stephanie's point about like needing to think through that, and also we're going to try to get this packet to you within 2 weeks, as well as the survey. So let me think what we might be able to do for that. Just wanted to be transparent.
If you're open to recommendations, I'd be happy to forward some in the interim, but I hear you. Thank you very much.
Okay, any other last thoughts, comments, or questions? All right. Well, thank you, everyone. As always, I love these meetings. This is probably like my best meetings of the month because the discussions are so rich and I learned a lot. And I also just appreciate everyone's commitment and passion to this important effort. And also, again, advancing and promoting health equity in the state of Oregon. So looking forward to getting out that nice hefty email with all these materials to review in a couple of weeks, and then looking forward to seeing you all middle of May. All right, have a good weekend, everybody.
Thank you all
Thanks,
so much for
everybody.
your time. Bye.
Thank you.
Take care.
Bye.
Great weekend.